So hi everyone. Welcome to the IMAA, the International Microwave Ablation Academy webinar. So I'm microwave in London today. My name is Oliver. I'm from Kenyon Medical, and I will be the host today. I would like to welcome and thank everyone for attending today. During this session, audience can send questions to the Zoom chat box, and they will be discussed after the presentation. Meanwhile, the whole session will be recorded for future education purpose. Now, please allow me to introduce our speaker today, Professor Dr. Pan Jie. Professor Pan is the Deputy Director, Chief Physician, Professor, and Doctoral Tutor of the Radiology Department in Peking Union Medical College Hospital. Thanks to Professor Pan for joining us today to share his great experience on microwave ablation in lung. Professor Pan, please.
Thank you for the introduction. I'm Dr. Pan Jie from Peking Union Hospital. I'm an interventional oncologist. And let me first to update my PPT first. 我看看共享 OK. Let me see that. Yeah. Okay. Can you see my PPT?
Yes, okay, we can see it.
So, it's my great honor and very happy to have a chance to talk with international colleagues about the ablation therapy in the area of lung cancer. And today, I just want to share some experience on the ablation treatment, both focused on the radiofrequency and the microwave. Okay, this is a noun, and I believe all of us are familiar with this organ. Okay, you know, in recent years, because the lung cancer is the incidence is raised top of the lung cancer in population. And so, number one, both the radiation indication and the death rate. Okay, so that's one of the hot point the clinical doctors focus on that. Today we'll talk about the lung cancer, both including the primary and metastatic secondary. The primary lung cancer as a pulmonary carcinoma. Mostly we want to non-small cell cancer in the lung, okay, because it's with a high mobility and mortality rates especially in China, okay. But in ablation areas, besides the primary lung cancer, we also do some ablation therapy on the metastatic lung cancer that derived from the GI tract. That's quite often a liver and even the urogenital system, breast, bone, soft tissue, etc. In talk about treatment options, of course, for the early stages lung cancer, of course, the surgery is the first choice. And for the advanced stage of the lung cancer, it is another hot point because the chemotherapy and the target medicine therapy, and both also the radiotherapy also is quite often used to the patient. So, but in our area, because the ablation therapy has their special advantages, for instance, microinvasive and very high efficiency in the treatment for the lung cancer. So in recent years, from the beginning of the 2000 years, I think so more and more patients and doctors like to choose the option, the treatment for the ablation. This is alternative therapies for the non-cancer. Mostly we do the patient in the stage 1 or stage 2 non-small cell non-cancer patients. If they cannot accept surgery because of the mobility, afraid, or because of their over senior age or the patient's risk concern, etc., maybe they want to change their mind to go into our ablation choice. For the local therapy in the non-cancer, besides the surgery and our thermal ablation, of course, stereostatic body radiation, SBRT, is another choice. Today we talk about ablation. We just want to focus on the thermal ablation because in ablation therapies, besides the thermal therapy, also have cranial ablation and other ablation choices. The mechanism of the radio frequency ablation and microwave ablation, because the time we will not talk about here, I'm sure both you guys were quite familiar with that. This is the first case report about non-cancer treated with radio frequency in the world. It's by Dr. Jie Pan in 2000 as American professors. He first reported a non-cancer patient in the right lobe and treated with I think it's left lobe, and treated with radio frequency. This is the earliest report published in the AJR. This is some papers published in the journals, the meta analysis reported in the journal. We can, based on this, the meta summary results, we can take the we can find that we can see that radio frequency treat the non-cancer is safe and effective. Also, in recent, I think it's recent 10 years or so, because microwave ablations appeared originally from China as one of the pride of things as the Chinese doctors say. We are very happy to see and to use the microwave. So this very powerful tools and used in many solid tumors treated. So also we can see this is another meta-analysis. Many clinicals reported their the clinical studies. The results show that microwave ablation therapy treat the non-cancer also safe and effective. And we can see that the results, the follow-up years, and the overall survival rates from 1 year to 5 years, the follow-up, the overall survival rate is quite high, and with minor applications. So next, I'd like to use quite a little bit of time to show the method in China, how a Chinese doctor to do the ablation therapy under the guidance of the CT and to do the non-cancer patient. So this is a CT machine. I think it's quite a routine in every hospital. We can use that. And when the patients go into the CT scanning suite, first we need to train the breath hold. If we do the ablation therapy under the local anesthesia, we need to do. This is a very important step. We need to do that. Different doctors may have their own experience how to teach patient hold breath. In my own opinion, we just directly hold the breath, no inspiration or expiration. So it's if we do it well with the patient, we can let the patient to cooperate very well during our our procedures, especially the breath difference will not affect our treat and the puncture or the location. So the third step, an important step, we need to select a good position, a suitable position, either a supine, lateral, prone, or recumbent. Depends the location and of the lesion in the lung. This is let me see that. Okay. This is some mistakes. So after that, we need to scan the lung and find the lesion of the tumor in the surface of the body. We need just to the metal marker. Of course, in some new CT machine, we have the laser as marker system, so we do not need use this one. But in China, most CT hospitals still use the routine one. We need to the marker, the puncture site in the surface of the body for this patient. We first use a supine position, find the patient, the lesion is in the posterior lobe, lower lobe of the left. So it's quite deep. So if we do from the anterior front spot, it's quite difficult and may injure the lung tissue a lot. So we change another position with quite lateral and post prone position. So from this position, we can see that we can very clear to show the lesion and has a very convenient puncture route. So that means find a suitable position in the CT table is quite important before we do the puncture. So after that, location is done and select the puncture path. So this is another patient. Okay, so we marker with a pin in the surface of the body and do the puncture. This is a microwave ablation procedure. So we puncture into the tumor with the antenna, so under guidance of the CT images. So after that, then we repeat the CT scanning. So we can see that the antenna tips in the first, I think is about 3 to 2 centimeters and depth go into the lesion. So here's the point. When we punch the lesion, the tumor, we can say that a thinner usually is back to 1.5 centimeters. That this is the energy spread point. So when we do that, we suggest we'd better do the puncture the tips of the antenna ahead into 0.1 centimeters. So that makes sure the energy and the heat will spread enough to cover all the lesion. Then when we make sure the antenna is going to the right place and into the lesion, the tumor, then we start our ablation. We need to set the suitable ablation parameter. That means the power and time. So this is quite important. Usually we need to more and more practice and get your practical parameters and experience. You know how big and the size of the tumor, and you need how much power and how much time. So that's of course the company, the machine company, when you give you some suggestions, but that's only the reference. So you need to gain your own experience based on your practice. This is some suggestions need to show the size, different size of the tumor needs a different option of the antenna. For the non-cancer, if the patient the tumor size is belong lower than 2 centimeters, usually one antenna it's enough, and you can. But one antenna, one ablation shot, that's okay. But if the tumor size is bigger than 2 centimeters, but less than 3 centimeters, then we can use both 2 antennas. It's okay. But if we do not have enough money, we need to save money. One antenna with multiple shot with ablation, that's fine. But if the tumor size is bigger than 3 centimeters, I highly suggest more antenna combined a shot. But make sure we have enough ablation power to kill the tumor. That's some basic introduction about the ablation procedure we did in our non-cancer treatment. Finally, I'd like to share some experience and with some cases we did in the recent years, including some complications. The radio frequency and microwave comparison. So here's some experience. It's maybe not correct. Just to give you some kind of very roughly feeling to show what's the difference in between the microwave and the radio frequency when we do non-cancer ablations. So first, I like to say microwave. Microwave, it's of course first appear in China. So it's one of my favorite tool I like to do when we do the ablation tumors. So this ablation tool is like a rose. It's hotter, faster. It's very powerful. So when we do some big lesion ablations, and if you have a lot of patients need to do within 1 day, you need to repeat it, do more patients. So microwave is, of course, your first choice. So I think in China, in our hospital, and at least 1/3 of the patients, both in lung cancer and liver cancers and other cancers ablations, we treat it with microwave. And as to radio frequency ablation, it's like a white rose. It's less hot. We need more ablation time to treat the patient. But why we have to use the two chem tools in the lung cancer tumor ablations? Because they have they have advantages and disadvantages. Microwaves as sometimes is not so good at the control potentials. For instance, if we do some dangerous area tumor treatment or small tumor treatments, maybe if we cannot handle rightly with the microwaves, the energy time maybe have some risk. So in that point, radio frequency has its advantage. It's a good control potential. It's very, how can that, quite mild, so easy to control. So if in some special areas, sometimes I like to use radio frequency to take the treatment. So the questions in the selection on RFA and microwave, how to select that? Generally speaking, no standard rules. Mostly depend on your experience. In my experience, especially in recent 5 years, because we gain more and more experience on microwave, so we have more confidence on control of the manipulating the microwave machine. So because we usually do a lot of patients in 1 day, so we need to hurry up, so to buy time. So that's we use more and more the microwave to treat the lung cancer. But in high risk ablations, RFA recommended. So I will show that in the following cases. But if tumor is less than 2 centimeters, there is another spot. It's shortages on RFA because lung cancer has quite high impedance of lung. So if the tumor is a little bit small, less than 1 centimeter, sometimes when we do that, when we treat with radiofrequency ablation, sometimes we stop to work so suddenly. So that's another kind of shortages. Sometimes we have to meet in our treatment of lung cancer patient. This is examples. It's a 55 years female. It's a metastatic oligometastatic tumor. It's ovarian cancers, but you can see that the location is right on the right hilum. So it's a high risk spot. And we just we use the radio frequency with one antenna. It's at the Salem radio frequency. So with very I think it's 9 minutes with 2 centimeters in size of the ablation area. So after that, we do the enhanced CT scanning, show that the lesion is totally ablated, but the surrounding structures, both the bronchia and vessels, and avoid it. So that's we can show from this patient, we can see that the radio frequency treat the high risk area lesions do have their own advantages. This is another patient. Of course, it's a senior patients. That's why they choose ablation therapy and avoid the surgery with a small patch lesion in the right anterior lobe. We can see that here. The CT and PET CT results highly suspect it's malignancy. This is a PET CT scanning. You can see that it's a high metastatic lesion. So we do biopsy first. So this is some small tricks I like to show you. It's quite it's our own experience in our hospital how to use some special method to avoid the biopsy complication bleeding. So we do biopsy first. The biopsy results show that it's a pulmonary adenocarcinoma with T1A. So after that, we use one antenna microwave simultaneously in one step. Okay, because this patient I think is due quite at least 5 years ago, with a high energy. It's 60 kilowatt and with 6 minutes ablation time. And after that, we can see that GGO. That means it's a ablation area is fully covered the lesion. It's of course it's in one shot totally killed the tumor. It's a complete treatment. And in ablation, during ablation treatment, which highly suggest biopsy is necessary for every primary non-malignancy before we do ablation treatment. This is our experience. We show the biopsy steps quite similar. We see as I talked before. This the puncture step with biopsy and suit. After we usually we take 3 shots, get 3 tissue, 3 slides of tissue, go to the pathology, and to prevent hemorrhage, we have some experiments. We will use the gel foam paste. It's very useful and very easy. So I highly recommend it to you guys. Okay, how can do that? Because we use a quite thick needle. After we take the biopsy, we just load the gel foam paste go into the syringe, and through the puncture needle and inject the gel foam paste through the needle going to the puncture site. Then after that, we need the core of the needle and repeat to repeated it to go inside to the needle and make sure the gel foam, most of the gel foam go into the puncture site and how can that to ablate to thromb the the puncture site, make sure no hemorrhage happened. So I think in at least almost, I think 7 to 8 years, I cannot remember clearly, in my group, at least over 2,000 patients, we do the biopsy. After that, we use the gel film to treat to prevent hemorrhage. It's very, very useful. As to another important spot in the when we talk about when we see the ablation treatment, it's the timing. So when we to do the ablation, how to select the patient, that's quite important, because in our clinic, we see that when we treat the non-cancer patient, the ablation treatment is a little bit competitive with traditional surgery. So that's it's sometimes make our ablation oncologists quite hard or difficult to get in a patient, or get your the right patient, or to have the patient from the other doctors. So that's it's quite tough, I think, sometimes. So if you want to have more patient and to take the ablation treatment, so need to have you need to I could say that, to show your right treatment or decision in front of the other clinical doctors, especially surgery. So that makes sure if you convince them, after that you can get more patient, more chance to do these procedures. This is a little bit experience on that. So or maybe some mistakes in the frequency of the PPD. So here I like to show some advantages and disadvantages of the biopsy plus ablations. So when we do biopsy and ablation at the same time, so the advantage is that we can get pathology evidence and prevent hemorrhage due to biopsy. So you know that. So this is another reason. Sometimes when we talk about with the patient, we see why we want you to do patient to do the biopsy and the ablation at the same time, because when we do biopsy, after that we do thermal ablation, so we can reduce the rate of the hemorrhage. And so if we do that, if we do this procedure, so we can make us to pursue more non-cancer patients to accept thermal ablation. So that's one of another advantages. But in terms of the disadvantages, this procedure may have no pathology evidence or even have the benign results. For instance, after the results of biopsy back, we can see that the result maybe is not a cancer, it's maybe that tuberculosis. Okay, this we met in the patient we did before. Here, the case will show the GGO. You know, in the recent 3 years, especially the newer coronavirus disaster, you know, spreading in the world. So more and more people like to do the CT scanning with the non. So the results show that more patients happen to find they have GGO lesion in their non. So that's another quite interesting phenomenon. So how can we do with the GGO small nodules? So this it's a highly complicated opinions in the clinicals. Different doctors may have different opinions, but in this area may have as for us, the ablation oncologist, we get more patients to do that. So here's the case to show that the GGO patient and GGO nodule even is how can I say this carcinoma in situ, a very early stage, or it's stage 1 adenoma. I think for the pathology and the results is quite different with the other kind of adenocarcinoma of lung cancer. It has a good results. So that's why sometimes we are like to very active on that and to talk with patient and let them to accept our thermal ablation. So this is 5 years female because happen to have a GGO like node, very has a high frequency of anxiety. So after we talk, she accept my suggestion and accept the microwave ablation. So this is before ablation. We show the CT scan of that. This is puncture antenna going to the GGO nodes. We do the ablation, and it's ablation time. Just during ablation, we repeat. Here is we were actually during we do the non-cancer ablation. If we do that under CT scan, is highly recommend. We need to repeat the CT scanning in the between of the ablation time. So, so this is we can show that this the heat area is spread out, fully covers the GGO lesion. This is after treatment of the 6 months. We do the check CT scanning. We can see that the GGO lesion disappeared, and we can say that in the lesion it's only if I find as a liner, so fiber like scar lesion show here. So this picture indicates that show that only one shot of a microwave. It's a very short time. Just I think let me see how can I can't remember the parameter of the ablation time. I think right now we just use 40 kilowatts, maybe 1 or maybe 2-3 minutes. That's okay. That's enough. So do need for the small lesions, we will not use a high voltage of a longer ablation time. So just to avoid the some complications. So complications. In talk about the complications in the ablation of lung cancer, I like to see although it's quite safe, but compared with other tumor complication treatment, lung cancer ablation treatment has relatively higher frequency of the complication rates, and both the cases rates and the virality, and sometimes it's quite tough to treat the complication. So this is some complications. We can see that some our colleagues reported in the journal. See, you can see that the pneumothorax requiring a chest tube. It's quite is quite I think it's almost 50%. peripheral effusions, that's it's okay. And bronchial pleural fistula, although the rate is quite low, but if happened, it's very tough to treat the complications. It's a headache, I think, for doctors, both doctors and patients. Hemorrhage, pulmonary hemorrhage, relatively high, but not it's not okay. So usually we need to have some special measure to treat that. And reactive pneumonitis, it's I think it's in our experience it's much higher. I think at least 10%, but it's okay. You need to some special care about that. So here's the death rate. As you see that 1.6, it's quite low. And in our hospital, I think in 10 years, we do not have any death in our it's related to our ablation treatment. But if we reportedly have that, we need to care and concern about that. So also in microwave ablation has the similar rates of the complications. We can see that. In the following slides, I'd like to show some real complications in our hospital. It's my patient do that. This is a 68 years male, has metastatic lesion from HCC. I don't think it's a typical metastatic lesion, but because of it's recommended from liver surgeon, they insist that we need to do local therapy, so we need a radio frequency. So 1 probe radio frequency. This is signal. Pulmonary hemorrhage first. Okay, it's a minor complication. I don't care, but some interesting things happened. We can see that after we adjusted the puncture antenna, we can see that some air bubble within the aorta and the heart. We can see that. That means it's show that the air embolism at the left ventricle and aorta. So it's quite rare complication, but very dangerous. So after that, we just stop our procedure and make sure the patient within same supine position directly going to the ICU and keep observing. After 24 hours, we repeat the CT scanning, show that the air is solved automatically. So this another real complication. You can see that it's also it's a metastatic malignancy ablating with microwave. Of course, it's not cranial. It's another patient we get from our hospital, broken and retaining the tumor. So in recent 5 years, I think in Beijing and all the hospital, we use a microwave or do not have such kind of complication anymore. I think it's because it's an advance of the technique in the microwave antenna in production. I think it's the main reason. So we almost hear about that. It's another complication. You can see that metastasis of HCC, another also of now microwave 5 minutes, 3 shots. Okay. This is early years we did a case. If we do this case right now, we will not use my 50. This is a high voltage, maybe 40 watt hertz with 3 minutes once per shot, maybe it's okay. After that, we can find that patient suffer from the hot or breath and breath and the pain. So we do the CT scanning. We can see that the tension thermotherapy. This is 2 months later. So it's a delayed complication. Because the tension thermotherapy, we do the puncture drainage. It does not work. You can see that. Subcutaneous emphysema occurred after clamping of the tube. We waited, observed 4 weeks of drainage. No good results happened. So that's just a typical case of the bronchopleural fistula. It's one of the rare but very severe complications. So after that, we have to ask help from the thoracic surgeon. So they did the segmental nephrectomy. So, but the good news was that the results show that pathological results show that this lesion is totally ablated, no lymph tissue or cells occurred. It's totally necrosis because of ablation. So this patient showed that some failing. First thing is bronchopleural fistula is very dangerous complication. We need to try our best to avoid such kind of real application happen during our ablation. The reason, the key reason to have that, because I think is overheated, the high voltage of the energy to make this complication happen. Another experience is that we need when we do the non-cancer of the thermal ablation treatment, we need to have some friends in the thoracic surgery. So if such kind of complications and bad things happen, we need their help. So this is another key points. So because such kind of complications happen during our non-cancer ablation treatment, so we need to something we need to make sure to clarify this unusual complications. Need to have a thorough talk with the patient and the relatives in China before we do this treatment. That's pretty important. And a final experience we need because the ablation therapy is a local treatment for the non-cancer. Of course, for the early stage patient, it's fine, it's okay. But for advanced stage of non-cancer, it's not enough. Usually we need to combine with other therapies, okay? So this is example. It's a 52 years female with non-cancer adenoma. I think it's stage 4. Okay, suffer repeated hematasis and after systemic treatment. So how can we do that? What we can do? So we do embolization of the tumor through bronchial arteria. This is another key procedures we do in our oncologist, interventional oncologist. So unfortunately, we can't to open this. We can do that. I don't know what happened. So after that, we did a radio frequency with this lesion. So the results is after the embolization and radio frequency treatment, the patient's hemostasis was totally controlled. So we make sure the patient has quite the result of the treatment. This is another case it's also senior male with a small mass of left to lower lobe. Biopsy is done before ablation. Of course, we do the ablation with the microwave. It's because the lesion of the tumor, the size of the tumor is bigger than 2 centimeters. So it's with one single antenna, but multiple ablation shot. 60 watts with energy, with ablation time is treatment time is 6 minutes with one shot. The check CT scanning show the results. It's good. It's good. And 1 month follow-up with enhanced CT scanning shows that a little bit with the cavity and circular enhancement. But the results is not good. The pathologic results show that it's small cell carcinoma. So this patient we need to transfer to another oncologist to make sure the systemic treatment to guaranteed. Okay. This is what I want to talk mostly in today this talk. Finally, I need to some little bit of summary. Thermal ablation of the non-malignancy and in our clinical practice through this, I think it's almost 15 years practice, we show that it's quite safe and effective. And biopsy and ablation is highly recommended during our procedure. Okay. However, the ablation is only one of local therapies for lung cancer. So sometimes combination with other therapies is quite necessary. Although this kind of treatment is good and safe to the patient, it's very new and very how can I say that, not so powerful in clinical, especially in the area of the lung cancer treatment. So how can we get more patient and more powerful in this area? We need to do some high, how can I say that, high rate of the clinical research. So if we had more powerful results on that, we can convince them to accept us. So in this area, I think for us, especially our oncologist, interventional doctors, there's still a long way to go. So I hope or wish someday we can have some more chance or to do some corporate work on that. Maybe can help us to get more powerful in the treatment of the lung cancer with thermal ablation. So that's all I want to say in today and tonight. Doctors, thanks a lot for your listening. If you have any questions, we can talk. We can have some time to share with that. Okay, thank you.
Thank you, Professor Pan, for the great presentation. And I think we have some questions in the chat box. I'll just share my screen. I already. So, Professor Pan, can you see the questions? So here are some questions we got from the chat box in Zoom.
Let me see that. Okay. What did? Okay. Okay. I see. There are two questions, right?
Yeah, two questions
Okay.
so far. And I
First,
think there
why
are two
should
more.
we prefer microwave ablation? Yeah. I think I mentioned a little bit in the front the talk. The microwave compared with a radio frequency and other ablations, I think microwave is the most powerful ablation tool energy to kill the tumors. Especially with if the tumor with a big is quite huge in size. Actually, we do a lot more in liver cancer. In recent years, we have some experience on the big non-HCC tumor treatment with microwave. Even the tumor size is bigger than 5 centimeters or in 10 centimeters. We repeat with 3 attender, and I think it's at least 2 or 3 rounds repeat ablation. So most the HCC lesion even bigger than 10 centimeters, we can totally ablate it. So that's the one of the advantages of the microwave. Another advantages of microwave is faster. So compared with the reconfiguration, we need as an example. If the for example, if the lesion we do the non-cancer is a lesion, if the lesion is 2 centimeters, is with one antenna with a radio frequency, at least 20 to 3 minutes. Okay, but if we use the microwave ablation, only 5 to 10 minutes, that's enough. So if you want to ablate a patient, if you want to faster, you want to do more patients within 1 day with your working time, I think microwave is your choice. Okay. In metastatic non-deposit, what is the maximum number for ablation? Okay, that's a good question. The non-deposits, actually, we do not have the critical number for if more than that, we will not do that. In my opinion, we have experienced even metastatic patients in one lobe, in right or both, either right or left lobe. If the number of the lesion is less than 5, I think we can repeat it to redo that. But this is how can I say that? It's complications. Okay, complicated questions. We have more as a different idea on liver. But in liver, in metastatic lesion, for if we see to the neuro NEC, just neurological metastatic lesions. In my patients, the maximum number is 14 lesions we ablated within 1 hospital time. Okay, 1 treatment. So the lesion, okay, good time. Usually lesion, metastatic lesion is quite not so big, less than 3 centimeters. It's fine. But if the lesion is too big, bigger than 5 centimeters, we will not recommend we do the local ablation treatment. Okay. The third, number 3 questions, maximum distance between lesion planned for ablation and great vessels, main branches should how many? Okay. Frankly speaking, in my patient I don't care about the safety distance. We even the lesion is totally attached to the for instance the great vessels or main branches, I still have the how can I say that I dare have the how can I say that also do the direct treatment with ablation. But the key point is that you need to control the voltage, the energy, and the time. Usually we need to lower energy as a shorter time to do that and repeat it to do that. Okay, one shot is not enough, but because if you have the if you need the safety distance between the lesion and the important structures, may need to have the risk to maybe some tumor we cannot totally ablate it. So that's the point. So if you can have the powerful or a very confidence on that, on the control of this ablation tools, you can do directly. I don't care about the maximum distance. Okay, so the 4 questions. Number 4 question: how to keep Athenia safe from chest wall? Okay, cardiac great vessel. I think it's quite similar a question as number 3. And usually we need to inject some liquid, some even anesthesia liquids to make the artificial safety layer to avoid the injury of the chest wall or cardiac great vessel. Sometimes we do that. Okay. Yes. My one case is very close to the cardiac, yes, but it's not. It's quite safe. I think if you with how much energy, how much time to can ablate the how big in size. If you can have the very clear picture in your mind, sometimes I don't think it's that dangerous step to do that. I think it's quite safe. Okay, but in recent years, I think in last month, I have some one patient complications, injured the new nerve. This is a lesion located in the aorta window, just right in the right, in the left. Yeah, I think in left upper in the hilum left lobe. There is a small nerve. It's a refractory and narrow nerve branches just from the right, now under the arch of the aorta go to the left. Okay, so when we do that lesion ablation, injure that nerve, the patient lost his voice and can't drink. So during the first 2 weeks, that's quite severe complications. One of we happened in recent days. Okay. Yeah. Number 4 question: do you use antibiotics before ablation? No. And routinely we do not use antibiotics before ablation, but in some high-risk patient with infection of the lung, we do use some antibiotics after ablation. In the first after the first weeks, 7 days, 5 to 7 days, we need to just already antibiotics. Okay. Number 6, can we perform a lung microwave procedure with intercostal nerve blockage? Theoretically, I think we can do that, but I do not have such kind of experience on that. But we have some experience with when we do the some metastatic lesion in the thoracic wall, chest wall, and before we do that, patients suffer quite a severe chest pain. But after we do the ablation of the lesion with a microwave, the patient, the pain feeling disappeared after that. So maybe it's some quite similar with the intercostal nerve blockage, I think. But we do some injection of the other something like alcohol to stop the chest pain. With some patient we have such kind of experience on that. Number 7, for follow PET or sorry, follow-up PET CT or CT, which one you prefer? Good question. In follow-up, I think the golden criteria, of course, is PET CT, and that's for the traditionally non-cancer. Okay, but there are some exception. Is GGO, okay, lesion is less than, if the tumor less than 1 centimeter with the GGO. PET CT sometimes is not accurate on that. Okay, but in China, there are some how can I say that their own because of the money. Okay, the PET CT is quite expensive. Routine CT is quite cheap. So in our patient, if the for the GGO ablation patient follow-up, we usually do the routine, how can I say that, high resolution CT scanning. It's okay, but for the lesion is bigger than 1 centimeter or 2 centimeters, we usually do the enhanced CT scanning. It's a routine. But in my group patient, if the patient after the ablation treatment over 1 year or 2 years follow-up, sometimes we will suggest the patient to take a CT scanning. Okay, PET CT scanning, but it depends their financial support. Okay, most of them will not cannot afford the expansion. Okay. Okay. Number 8, can I do dissection or introduction of the artificial? Okay, good. Before microrevenation and the diaphragm improve the safety efficient procedure. Yes, that's a good question. Yes, I agree on that. We some of our colleagues like to do that kind of procedure during their ablation treatment. But in my group, we not often to do that, and especially artificial pneumothorax, we never do that. Okay, I think if you have very highly confidence to control the microwave, that channel, we do not to do that, especially the diaphragm. I think the diaphragm even close to lesion is not a problem because we have experienced even the metastatic lesion right located within the diaphragm. We can treat it with the ablation directly. That's no problem. Okay. That's all the question.
Yeah, there's just one more coming.
Okay. Number 9. At which intervals do we plan CT control in follow-up after microwave? 我看不见下边，现在。Procedure for lesion in non per camera. Okay. No golden criteria on that. In my group, we usually after we do treat the patient with microwave, the first follow-up time is after 1 month, the first month. Okay, then the 3rd month. This is the first 2 follow-up very closely. Then after that, every 3 months, repeat another follow-up examinations, and 1 year later, we were the time of the follow-up go to the 6 months interval. Okay, every 6 months we repeat the CT. Okay.
Okay, I think that's all questions for today. Thank you again, Professor Pan, for the fruitful discussion and experience sharing. Thank you very much. Yes, and yes, that will be all for today.
Thank you very much. Thank you everyone for your time. Thank you.
Yeah, have a nice day. Bye-bye.
Bye-bye.